So cataract surgery essentially is done these days by three common techniques. One is extracapsular cataract extraction. Then is the poor man's phacoemulsification, which is the small incision cataract surgery, in which a scleral tunnel is created. And then we have phacoemulsification, in which the size of the main port incision is very small and there is no need for a suture, and therefore the astigmatism after the cataract surgery is negligible. So talking about the extracapsular cataract extraction, in which the section is created after a superior rectus forceps has done the bridling of the superior rectus muscle so as to allow a good exposure of the superior area. After the muscle has been bridled, then a conjunctival peritomy is done from 10 to 2 o'clock so that the area is exposed. Then an incision is created from 10 to 2 o'clock. If you're doing a small incision cataract surgery, you can create a tunnel. The preliminary 3 steps would be the same. You can create a tunnel using a crescent knife, which again we talked about in our last webinar. After we have created a scleral tunnel, we do lamellar dissection and then we proceed. If we are doing an ECC, we just make an incision and allow a portal of entry into the eye. Some people have an alternative way. They create a tunnel and they do the entry into the anterior chamber via a keratome, which again we talked last time. That is in small incision cataract surgery. Always once an entry has been done, you want ports on the side so that irrigation and aspiration of the cortical matter can be done, and you can inject viscoelastic substance from time to time. And for this, we talked about the 15-degree side port knife in our past lecture. Once you have attained entry, it's time to address the anterior capsule, for which we do anterior capsulotomy. We talked about Utrata's forceps and cystitome in our last lecture. Now the anterior chamber opening has been created. We have access to the lens. The lens has to be brought out. Now that depends from surgeon to surgeon which technique they use. So here we will be talking about few instruments which help us to take out the lens and which help us to deliver the intraocular lens inside the bag. So one of these instruments is a lens hook and a nucleus loop. The nucleus loop is put at the section. If you are using a tunnel, it is used at the scleral tunnel section, or if we have an incision on the cornea, then you can do it to press the posterior scleral lip in ECC. The essential funda is that we are using a pressure counter pressure technique where the pressure is applied at 6 o'clock using the lens hook or lens expressor, and at 12 o'clock position we have the Lewis lens or nucleus loop. So as we put pressure on the posterior scleral lip, the counter pressure is put by the lens hook, and because of that rocking movement, the nucleus is delivered out. Remember, whenever the nucleus is more mature or the lens is hard, we need to have a big opening of the section. So if the corneal section is smaller, you don't need to struggle. You just need to enlarge the section so that this nucleus delivery happens smoothly. If you struggle, then the chances of a posterior capsular rent happening are very high. So depending upon the hardness of the nucleus, the section size should be enlarged. There are a lot of dynamics which play a role into the expression of the nucleus to the outside. So first of all, you have a counter pressure that you're putting at the posterior scleral lip. You are also applying pressure from the outside with the lens expressor here. And within the capsular bag and the anterior chamber, there is the internal hydrostatic pressure. The nucleus itself is also applying a stretching force on the section, which is counterbalanced by the forceps which you are using to hold the sclera. So you see there are so many factors which are coming into play. So for the smooth nucleus delivery outside, important thing is that you are well supporting the nucleus, the section is large enough, and when the nucleus is moving ahead, your lens hook should also move along with it so that it keeps pushing it out. The lens has come to this point, but your lens hook should not be at this position. If the lens hook is moved here, if the nucleus has moved to this point, the lens hook should also move at this position. So you have to move your 6 o'clock hand along with the nucleus and sort of push it out. So remember to always counterbalance the effect at 6 and 12 o'clock position. Then only you will have smooth delivery. If you are struggling, then viscoelastic should be used from time to time, because eventually what is going to happen is that endothelial cells are going to get damaged if you're struggling too much. So endothelial cell loss can happen, and which can lead to postoperative corneal edema. So whenever you're struggling, use a lot of viscoelastic as a buffer between the corneal endothelium and the cataractous lens. The uses of these two instruments are to deliver the nucleus in either the small incision cataract surgery or an extracapsular cataract extraction. They can also be used to remove the subluxated or dislocated lens. Now, the difference between subluxation and dislocation should be clear to everybody. Subluxation means that some of the zonules are broken, but the lens is still hanging in the patellar fossa with the remaining zonules. Dislocation, on the other hand, means that all the zonules are broken. The lens is a free bird. It can either come into the anterior chamber or go behind in the vitreous cavity. So if the lens is in the anterior chamber, you can just glide it out using these instruments. So pupil should be adequately dilated before introducing the wire vectors or the nucleus loop. And one should go between the lens and the posterior capsule and beyond the lens edge, so that the entire nucleus is supported on the glide and you can glide it out smoothly. Be careful not to catch the pupil margin, otherwise you will catch the entire iris along with it, and it will cause iris root detachment and result in iridodialysis. Always lift up the lens and then withdraw out. Don't just drag it like that. That will help to give a good support to the lens material, and it can be drawn out and much smoothly. This instrument, which has a very small hook, blunt hook in front, is called as a Sinskey hook. You must always feel the tip of the instrument. It's not a very sharp tip. It's a blunt, small curved hook. This instrument is used to dial an intraocular lens in the capsular bag. The hook is positioned in the dialing holes of the optic of intraocular lens. Now, dialing holes are present only in the PMMA lenses. Most modern day lenses, even if they are PMMA lenses, don't have dialing hooks. So if there is no dialing hook, then this Sinskey hook is engaged at the junction of haptic and the optic. And it is used to dial a intraocular lens into the bag in a clockwise manner. It might be used as a left-handed or a second instrument. Remember, whatever you use in your right hand or your dominant hand is your first instrument. Whatever you use in your non-dominant hand is your second instrument. So if I am doing an irrigation aspiration and I am using an irrigation port in right hand, that is my first instrument. Or if I'm using a Sinskey hook to dial a lens with my right hand, it's my first instrument. But if I'm using two Sinskey hooks, or if I'm using another instrument, which we will be talking about subsequently, then this Sinskey, which is in my left hand, becomes the second instrument. So as a second instrument, if you are trying to rotate the lens, just rotate the lens, it can come in handy. If you're trying to break a cataractous lens into two pieces, then also it can come in handy. You have to use any instrument which has a bend, be it a Sinskey hook or be it a chopper or be it a Y instrument that I will be talking about. One must remember that your hand should be parallel to the iris. You should never bend it in a way that this hook can penetrate the posterior capsule and result in a posterior capsular rent, which will bring the vitreous into the anterior chamber. So be very careful.